So thank you very much, Rohini, and hello, everybody. Thank you very much for joining us this evening. And thank you very much, plant-based health professionals, for inviting me to talk to you today about plant-based diets for treating type 2 diabetes and its complications. As Rohini said, my name is Dr. Sundhya Raman. I'm a medical doctor. I also have a PhD in genetics and epigenetics, as well as a qualification in lifestyle medicine from the International Board of Lifestyle Medicine and the British Society of Lifestyle Medicine. And I work as a lifestyle medicine doctor at My Wellness Doctor, which is a company that I co-founded. And I was particularly happy to be talking to you about type 2 diabetes because it's the entire reason that I came to lifestyle medicine. So this is a picture of my mum and my dad, and they both have diabetes. But actually, it is my dad in particular who has suffered the consequences of diabetes. So he was diagnosed when he was in his 40s. And by his 50s, he had had multiple silent heart attacks. He has had open heart surgery. He's gone on to have stents into those grafted vessels. By the time he was in his 60s, he was starting to lose his vision. And by the time he was in his 70s, he was completely blind from diabetes. And this has meant that he has never actually seen the faces of 3 of his 4 grandchildren. And he has completely lost his independence. And this is a little diagram of my immediate family, and there in orange are my mum, my dad, and my sister, and they all have diabetes. And I'm there in green, I don't have diabetes. And looking at my extended family, well, both sets of grandparents, most of my aunts and uncles, they all have diabetes. Now, bear in mind that they are predominantly lifelong vegetarians. They tend to cook from scratch. Only 2 of them have ever been smokers. They tend not to be obese. So really, when they're doing so much right, where has it gone wrong? And it wasn't until my mum's youngest brother, who was diagnosed with diabetes when he was in his 40s, had started to show by his early 50s some signs of damage to his kidneys. And then he started to show signs of damage to his eyes. And he was really worried, as you can imagine, knowing my own father, that this could end up being him. And he came to me and he said, well, what more can I be doing? And so what I'd like to talk to you today about, if you are a healthcare professional and you're caring for people with diabetes, if you or your loved one has diabetes, I hope you'll come away from this talk really having more of a sense of what you can be doing in order to change your outcomes. So I'm going to frame my talk, first of all, by talking about the scale of the problem of diabetes worldwide and here in the UK, and then just outline our current approach to diabetes and its limitations. And then I'd like to just outline a new paradigm for how we can be thinking about diabetes. And finally, a summary of the main points and what you can take away from this talk. So this graph shows our worldwide prevalence of diabetes. And in 90% of cases, what we're talking about is type 2 diabetes. In 10% of cases, we're talking about type 1 diabetes. This is an autoimmune condition. And this is really where the pancreas isn't producing insulin. In type 2 diabetes, the pancreas is producing insulin, but our cells are not responding to insulin the way they should be responding. In the year 2000, we had about 151 million people worldwide with diabetes. In just 10 years, that had risen by 100%, and within 20 years, by 300%. By the year 2045, we conservatively predict that the worldwide prevalence of diabetes will be 700 million. And I say this as conservative because it assumes that our levels of obesity will remain static. So in truth, it's probably an underestimate. Now, a diagnosis of diabetes really carries with it, it doubles your risk of dying of a cardiovascular cause, such as a heart attack or a stroke. So really, the majority of efforts have really focused on trying to drive down mortality from diabetes, and we've had some significant success with that. So within the last 20 years, mortality from diabetes has halved. But in that same time frame, disability from diabetes has gone up by 75%, which means really there are a lot of people out there, much like my father. So About half of diabetics will develop diabetic neuropathy, which is damage to the tiny nerves in their hands and their feet. This puts them at increased risk of foot ulcers and therefore of amputation. And in England alone, every single week, 100 people have a limb amputated because of diabetic neuropathy, because of the complications of diabetes. It is the most common cause of end-stage renal failure. And it is also the most common cause of blindness in people of working age. So what is our current model? What do we think happens to cause diabetes? Well, we think we're eating too many calories, particularly high glycemic index calories such as bread and rice and pasta. And ordinarily, these would be stored in our liver and our muscle as glycogen. But when those stores are overwhelmed, we store those calories as fat. We store them inappropriately, not just in our liver and in our muscle, but also around our abdomen and even in small amounts in our pancreas. And that fat causes inflammation and it starts to damage the cells. And then those cells start to become insulin resistant. And so they don't really respond to those levels of insulin, and they don't push that glucose that's in the blood into the cells to be used as energy. And as a response, the pancreas starts to push out more insulin. Now, insulin does other things. What it also does is increases our appetite and it helps us store fat. As you can see, we start to get a vicious cycle where there's more insulin driving more fat being deposited around cells in our liver and our muscle, causing more insulin resistance and causing the pancreas to push out more insulin to try and lower that glucose in our blood and push it into our cells again. But when that system gets overwhelmed and the pancreas is no longer able to produce enough insulin to lower that blood glucose and push it into the cells, we tip it over into diabetes. And therefore, the holy trinity of diabetes management has been to use medications to reduce our blood glucose, to reduce the cholesterol in our blood, the fats in our blood, and also to improve our blood pressure, because a lot of diabetics have high blood pressure, and this also carries with it an increased risk of poor cardiovascular outcomes. So there have been a lot of trials looking at what happens if we really try and optimize our blood glucose or our blood pressure or our cholesterol. And what they've typically done is they put people into two groups where they either intensively or less intensively treated either their blood glucose or their blood pressure or their cholesterol. And they've thought, well, look, what if we normalize these? Do we get better outcomes in diabetics? And here are the results of those trials. So on the left is what is comparing intensively and non-intensively treated blood glucose. In the middle is blood pressure, and on the right is cholesterol. And the boxes in green show us really where we have had some benefit from intensively treating these three things, each of these things. The boxes in blue show us where there was really no difference between intensively treating and non-intensively treating. But importantly, right at the bottom, we have these two boxes in orange. And what we found was that if you have a longer duration of diabetes, or you have known cardiovascular disease, and you intensively treat blood glucose, you actually increase the risk of all-cause mortality. And in fact, one of the trials was stopped 3.5 years early because of excess mortality in the intensively treated group. In the middle here, we see that in the trials that compared intensively and less intensively treated blood pressure, those with a baseline blood pressure of 140 millimeters of mercury or less, or a target blood pressure of 130 millimeters of mercury or less, actually had an increase in all-cause mortality when they were intensively treating blood pressure. So one question to ask here was, were we inappropriately driving down blood pressure, or were we inappropriately driving down blood glucose and causing an excess of hypoglycemic events? Well, if we look at these blood pressures, we think of a normal blood pressure as being 120/80. That top number, 120, is our systolic blood pressure, It is the pressure in our blood vessels when our heart contracts. And actually, these blood pressures are still in the hypertensive range. They're still high. So no, we weren't actually inappropriately treating blood pressure. And no, they didn't find an excess of hypoglycemic events that explained this increase in all-cause mortality when we aggressively treat blood sugar in diabetics. In fact, we don't really know why there was an increase in all-cause mortality by, intensively treating blood glucose and blood pressure in diabetics. One possibility is that actually what we're doing is we're stifling the body's compensatory mechanisms. They're trying to perfuse organs within damaged blood vessels. So really what we're doing is we're treating a symptom of diabetes and not the actual cause. So one thing I'd like to say at this point is, should we be questioning the role of medication in diabetes? Well, yes, we need to have some awareness of where medication sits in the way we manage diabetes. And really, I would like to say it's not a panacea, but actually that medications do have a role. They do have their place. What is that place? Well, if you consider that somebody with diabetes or pre-diabetes, their metabolism is behaving like a runaway train. Actually, what medications do is they act like a brake on that train. They slow it down, but they do not reroute it on a path towards healthier outcomes. And now for the second part of my talk, I'd like to introduce another way of looking at diabetes that does reroute you towards better outcomes in diabetes. Before I go into that, I'd like to just see, I'd like to just address, what is actually wrong with our current model of diabetes. And nothing really significant apart from the fact that it acts so far down in the process of what happens in diabetes that it's very difficult to leverage much control at this point. But the other really important thing is that we oversimplify food. We talk about it in terms of its glycemic index, in terms of calories, but actually food is much, much more than that. It's information. Now, how does food impart information? How is it translated by our bodies? Well, there are three main mechanisms: epigenetics, chronic inflammation, and our microbiome. And to begin with, I'm just going to outline what each of these things are. So epigenetics is how we switch our genes on and off. So our genetic code, our DNA, that is fixed. And this is the manual to make every component of a human being. But our epigenome is how we switch those genes on and off, and that is malleable. Now, we know that we inherit our epigenome. So in my case, I have probably inherited an epigenome from my grandparents, my great-grandparents, that increases my risk of developing type 2 diabetes. What I think is really, really heartening is that I can modify my epigenome through my behaviors. So that makes me much, much less likely, by having healthy behaviors, much, much less likely to develop diabetes despite the epigenome that I have probably inherited. The other aspect is chronic inflammation. Now, there are two types of inflammation: acute inflammation and chronic inflammation. Now, when we talk about acute inflammation, this is the kind of inflammation you get when, say, you cut your skin. And what happens is your immune system and your inflammatory mediators go to that site of the cut and they repair it, they deal with it, and then they shut down. And this is appropriate and healthy inflammation. It primes our immune system. It's good for us. The type of inflammation that I'm talking about here that drives disease is a chronic low level of grumbling chronic inflammation. And this is the kind of inflammation that we don't shut down. It makes us more likely to gain weight. It makes us more lethargic. It makes it difficult for us to recover from a chronic viral illness. And it also drives our risk of a chronic disease, such as diabetes. Finally, our microbiome. Now, this has been a really, really interesting area of research over the past few decades. So we have many microbiomes. For example, we have a microbiome on our skin and other places. But the microbiome that I'm going to talk about today is the microbiome in our colon, which is the microbiome at the very end of our gastrointestinal tract. Now, when I say our microbiome, what I'm talking about are the bacteria, the viruses, and the fungi that live there. And we know that we have an intimate and symbiotic relationship with them. So our behavior influences them, and they in turn influence us. So, for example, if we eat a lot of plant foods and a lot of fiber, this is the superfood for the bugs that live in our colon. And they ferment it to form short-chain fatty acids such as butyrate. And that butyrate in turn feeds the lining of our gut, the colonocytes, the cells that line our gut. And that layer of cells it's a very important barrier between the outside world in terms of the food we eat, in terms of the microbes in our gut, and our inner world, our bloodstream. And it's very, very important to care for that barrier. It's only one cell thick. And so our behaviors impact how good the junctions between those cells are. And in turn, our microbiome, it helps us absorb nutrients from our food. It helps us, they make vitamins, but they also switch genes on and off. So you can see that actually there's a complex and symbiotic interplay between our epigenetics, our levels of chronic inflammation, and our microbiome. And I said that food is information. So how does food impact on these different ways in which we communicate in our bodies? So for example, heme iron and nitrosamines in meat and fish, well, they are pro-inflammatory. So for example, nitrosamines, they are formed because nitrates are used as preservatives for meat and fish. And they react with the proteins in meat and fish, and they form nitrosamines. And nitrosamines are actually found in tobacco. They're one of the known carcinogens in tobacco. And they cause direct DNA damage. But they also drive oxidative stress. They activate pro-inflammatory cytokines, and they promote insulin resistance. So heme iron. Now, there are two types of iron. There's heme iron and there's non-heme iron. We get heme iron from meat and fish, and we get non-heme iron from plants. So one meta-analysis of prospective cohort trials, including over 185,000 people, found that for every 5 milligrams per day increase in dietary heme iron, we increase the risk of developing diabetes by over 3-fold. So that's really, really significant. Another prospective cohort trial looking at pregnant women found that for every 1 milligram per day increase in dietary intake of heme iron carries with it a 50% increased risk of developing gestational diabetes. Now, gestational diabetes, when a woman develops gestational diabetes, this not only increases her risk of going on to develop diabetes by about 70% over her lifetime. When they've done cord blood analysis looking at the blood of the fetus, what they found is that there have been epigenetic switches that increase the risk of beta cell dysfunction, insulin resistance, and dyslipidemia in the fetus, in the fetuses of women with gestational diabetes. And how much heme iron is this 1 milligram or 5 milligrams that we're talking about? Well, we think of red meat as being high in heme iron, but actually a lot of seafood is incredibly high. I mean, you'll see here, for example, clams per 3-ounce serving. Now, when I say a 3-ounce serving, that's roughly the size of a deck of cards. So it's not a very large serving. And even things like chicken, you know, as you see third from the bottom, tuna and salmon. So both seafood and meat, they all contain heme iron. And it isn't that hard to start to drive up your risk of gestational diabetes or diabetes. Now, saturated fat also and advanced glycation end products and new 5GC, these are other things that you find in meat and dairy. So saturated fat is found in literally every single animal food. It's also found in tropical oils such as palm oil and coconut oil. And one thing we know about saturated fat is that it is one of the main drivers increasing LDL cholesterol, and this is what we think of as our bad cholesterol. But there are other things that saturated fat does. It It has toxic metabolites that go into our liver and muscle cells and cause them to be more insulin resistant. But it also drives people with high saturated fat diets have something we call dysbiosis. So this is an imbalance in the good and bad bacteria in our microbiome. So what we find in people who have a high saturated fat diet is that you get an increase in gram-negative bacteria in the microbiome. And these gram-negative bacteria start to make that gut more leaky. They are not good for that gut lining barrier. And there are things called lipopolysaccharides in their cell wall. And because that barrier is no longer as tight as it should be, these drift into our bloodstream and they drive chronic inflammation. Advanced glycation end products are caused by increased intake of animal proteins, particularly when these are dry heated, such as barbecuing. And these cause cross-linking of collagen in blood vessels, for example. So it causes a stiffening of those blood vessels and it increases blood pressure. But also these LDL cholesterol particles get trapped in that cross-linked collagen. And so we get an atherosclerosis in those blood vessels. Now, new 5GC, when we eat red meat or dairy, what happens is we display something called new 5GC on the outside of our cells. And our immune system sees new 5GC and it identifies those cells as not belonging to us. So it actually causes an immune reaction when we consume red meat and dairy. And so this also drives chronic inflammation. We know that choline and carnitine from meat, they foster bacteria in our microbiome that produce something called trimethylamine. And this then gets converted to trimethylamine oxide in our liver. And this also drives atherosclerosis. It drives inflammation. Another thing that we find in dairy is things called microRNAs. And these are epigenetic modulators. They're completely normal, but they're completely normal until we are weaned. And after that, the levels of microRNA, if we're not consuming milk, those disappear. But if we reintroduce dairy into our diet, cow's milk into our diet, we reintroduce these microRNAs. And what we've found from animal studies is that these microRNAs, they affect the beta cells in the pancreas and they inhibit their ability to produce insulin. In fact, they regress the development of beta cells in the pancreas in animal models. So we've looked at a range of foods and how they negatively impact our epigenetics, our levels of chronic inflammation, and our gut microbiome. But on the plus side, fermented or cultured dairy products such as yogurt and cheese, they have probiotics in them, which means they are filled with bacteria, live bacteria, and so they repopulate our gut microbiome. But it's really important to point out that you do not have to have dairy to get probiotic. You could have live soya yogurt, you can have fermented vegetables such as kimchi and sauerkraut, or you could have water kefir or kombucha. So there are other ways to have those probiotics without the saturated fat, without the new 5GC, without those microRNAs. And what about plant foods? Well, plant foods are full of antioxidants, so they drive down chronic inflammation. They are full of fiber. In fact, animal foods have zero fiber. They are only found in plant foods, and they are the superfood for our gut microbiome. They rely on the fiber in our diet in order to thrive and remain healthy. And there's another area that has been really fascinating, which is an area called nutrigenomics, which is how compounds within plant foods affect our epigenetics and set us on a path towards healthy longevity. For example, we know that things like curcumin in turmeric and things like sulforaphane in cruciferous vegetables and various polyphenols, they switch on housekeeping genes that reduce our risk of cancer, also improve our metabolism. So actually plant foods act in multiple ways to improve our likelihood of having healthy outcomes in our lives. So we understand the devices that our body uses, either to set us on a path towards healthy longevity or on a path towards chronic disease. We also understand a little bit about the drivers. We know that the foods we eat have a significant impact on these devices. There are other things that also impact. For example, getting good quality restorative sleep is a really anti-inflammatory process. We know we should be aiming regularly for 7 to 8 hours of sleep per night. And we know that when people get good number of hours and quality of sleep, the amount of leptin and ghrelin in there is regulated well. And these are hormones that drive our appetite. So in fact, people who are chronically sleep deprived, they're much more likely to have increased appetite, to have a disarray of the levels of leptin and ghrelin switching around in their system, driving their appetite, making them more likely to be obese. And good quality sleep helps improve our insulin sensitivity. So it's a really important thing to also think about the quality of the sleep we get, the number of hours of sleep we get, and focus on this as another one of the pillars that help our epigenetics, our chronic inflammation, and our microbiome. We know that stress has a big impact on these devices. So acute stress, so having an exam or giving a presentation, these are fine. These are really not problematic. It's chronic stress, a chronic high level of cortisol. So cortisol is our stress hormone. It's a steroid hormone, and we know that steroids increase our blood glucose. The steroid should be anti-inflammatory, so cortisol should be anti-inflammatory. And when we have chronic high levels, we become more cortisol resistant and we don't shut down inflammation. And so chronic high levels of stress drive chronic inflammation as well in this way. We also know that our level of social connectedness is important to our health outcomes. The Centre for Disease Control in the States said that being socially isolated carries with it the equivalent health risk of smoking 15 cigarettes a day. And one randomized controlled trial looked at diabetics, and it randomized them to two groups, one where they had monthly peer group support, and a second group where they had monthly individual diabetic education. And after 6 months, what they found was the groups that were randomized peer group support had significantly better long-term glucose control, better HbA1c than the group that was randomized to individual education. So we understand the devices, we understand the drivers. But if we give, also things like exercise, they really impact on these various devices. And one thing I would like to say is that I've said about insulin and how it drives glucose into cells. What it actually does is our glucose receptor sits within the cytosol of our cells, sits within our cells. And when insulin comes along, it moves those receptors to the surface of our cells. But the other thing that does that is muscle contractures. Exercise is really important for sensitizing our cells, for moving glucose receptors to the surface. But it also acts on, it improves our chronic inflammation and our microbiome and all these different devices as well. But if we give the wrong signals over a period of time, we start to push these devices into a disequilibrium. And they will try and compensate. But ultimately, if they can no longer compensate, if we carry out these unhealthy behaviors for long enough, they will decompensate. And ultimately, this will lead to disease. And not just diabetes, but literally every single chronic disease that we know of. Chronic heart disease, chronic lung disease, dementia, chronic inflammatory diseases such as rheumatoid arthritis, and even cancer. So what if we were to take a different approach? So this meta-analysis looked at prospective cohort trials with respect to the risk of developing diabetes and in diabetics and what their health outcomes were. And it included prospective cohort trials that had at least 3 lifestyle practices that included but were not limited to the ones listed here. 16 of those studies looked at over 1 million people and said, well, if you have a healthier lifestyle compared with a less healthy lifestyle, what is your risk of developing diabetes? 10 of the studies, looking at over 34,000 diabetics, compared those with healthier lifestyles and less healthy lifestyles. And it wondered, well, what are the outcomes in diabetics if we compare a better lifestyle with a less healthy lifestyle? And here what they found was that in those over 1 million people, the likelihood, if you had a healthier lifestyle compared with an unhealthy lifestyle, of developing diabetes was driven down by 75%. And when we look at patients with diabetes and compare those with a healthier lifestyle and compared to those with an unhealthy lifestyle, the risk of cardiovascular disease, cardiovascular mortality, and all-cause mortality, and even cancer mortality were driven down significantly, much, much better than what we saw in those drug trials. So finally, to summarize, I think one really important thing to take away from this is that we need to have caution when we aggressively manage blood pressure and blood sugar in diabetics. A lot of times patients will think that they're on their diabetes medication and that pretty much solves their problem. But actually, what the results of these trials show is that's very, very far from the truth. What we need to have is a real focus on lifestyle. And it doesn't have to be an either-or approach. One other thing that is important is this trial that looked at how lifestyle management actually improves our response to diabetic medication. So this study, prospective cohort study in over 31,000 people with cardiovascular disease or diabetes with some kind of level of end-stage organ damage, was looking at secondary prevention of cardiovascular outcomes. And at the baseline, they looked at the dietary quality in these patients, and they mainly focused on plant foods, so their intake of fruit and vegetables, nuts and seeds, and whole grains, but also their intake of fish versus meat and eggs. And after 56 months, when they compared those in the healthiest quintile and those in the least healthy quintile, they found that actually secondary prevention was improved, so in terms of cardiovascular death, MI, and stroke. But it's interesting to see that this wasn't actually as impressive as those trials looking at adding in, at least 3 lifestyle interventions. And the other final thing to mention is that taking a lifestyle approach doesn't just improve your risk of diabetes, but actually every single chronic condition that we know of. And finally, I'd like to let you know what happened with my uncle. So here, these green bars represent the amount of protein that his kidneys were filtering. And the fact that they are in that red zone indicates that they were filtering large proteins that they shouldn't have been filtering. They were showing signs of damage. The blue line represents his HbA1c, or in other words, his long-term glucose control. And you could see that for the last 2 years before we did anything together, it was skyrocketing. Once we began our lifestyle intervention, his blood glucose started plummeting. His HbA1c improved significantly, and this is whilst he was coming off his diabetes medication. And these green bars showing the state of his kidneys, they've moved into below that orange zone. They moved into the safe zone. They were no longer filtering large proteins. They were showing signs of being healthy. And most importantly, September 2018, his eye screening showed that he had diabetic maculopathy. He had damaged retinas. By February 2020, there was no sign of any damage to his retinas. So thank you very much, everybody. These are my references, and I'd be delighted to take any questions.
That was absolutely brilliant, Sundhya. Thank you so much. I felt like that was incredible overview, and the story of your family was so inspiring. Would you be able to expand on how you supported your uncle to make the changes and the sorts of approaches that you use for behavior change with your patients?
Well, what's really interesting here is that, in fact, this was my very, very first entry point into lifestyle medicine. And so, in fact, our interaction was nowhere near the kind of interaction that I have with my patients now. So it was quite ad hoc. And as I was learning, I was letting him know what I advised. And he was actually not vegetarian at the time that we began. And but saying that, he was probably eating chicken once a week. He wasn't really enormously carnivorous, or he didn't have much meat in his diet even to begin with. So we began by focusing on really quite blunt tools, I'd say. We did focus on exercise, but I started to try to transition him to a completely vegetarian diet, and things like trying to mitigate glucose spikes by saying, we'll try and have some nuts with your fruit and things like this. And then when we went the whole hog, and I said, let's move completely to a whole food vegan diet, this is when we really started to see the enormous effect. This is when, in fact, actually, maybe, I don't know, when you actually look at that graph, what happens is, at first, it's shooting upwards before we start. Then the kind of trajectory sort of slows down, and then it plummets. And the slowing down was when we began a vegetarian diet. He was already incredibly active. He has a very active job. He played cricket every weekend. So although I was encouraging him to do more resistance exercise to improve his skeletal muscles, in fact, it was shifting to a whole food, plant-based vegan diet that had the largest impact. And I was just talking to him on the phone and giving him advice and saying, look, this is what I'm reading. And as he started to see the improvements, he was so wholeheartedly involved. And to this day, he doesn't really eat any animal foods. I think it seemed like quite a dramatic thing to do, but in fact, it really ended up being not very difficult. Oh, I can't hear you.
I'm muted. I was muted.
Oh, okay.
Yeah, so no, that's really inspiring to hear. And if you don't mind me asking, I know that you have children. Are they also plant-based now? Are you with your family? Do you follow a plant-based diet?
So yes, I mean, my husband and I are completely vegan. We At home, my children are vegan. My son is completely vegan. He's 12 years old. The reason we actually they've been lifelong vegetarians. The only thing we find is that when they go to places, so when they go on school trips, when they go to somebody's house, as soon as my husband and I became vegan, they identified themselves as vegan, and they were going to people's houses and they were refusing to eat anything. And so at home, they are completely vegan. Once my son, when he turned 12 and he had a lot more control over how he eats when he's outside of the house, he decided to become vegan. And my daughter, because she's 8 and she doesn't have that much control when she goes to people's houses, she doesn't feel she can just pop out and go and get something to eat. We've told her she's whole food, plant-based, vegetarian, but actually she tends, what I find really, really exciting is that she tends to choose vegan choices, and she influences her friends as well. So when she goes to school, she'll come back and she'll tell me, how a lot of her friends have been choosing the vegetarian option. And if there's a vegan option, they choose that vegan option. So in fact, they are great ambassadors as well. And the only thing that has limited me is when they're in a situation and they have no choice over what to eat. And that has been the only reason that I wouldn't say to my daughter that she is vegan, because it makes it very difficult out there. But certainly at home, everyone is vegan.
That's incredible. Some of the comments that are in the chat are just incredible, like absolutely brilliant, so beautifully explained. This lecture was stunningly awesome. I will send you some of those lovely comments. One of the questions I had is, obviously I'm from a South Asian background, and we know that South Asians have a far higher risk of type 2 diabetes, pre-diabetes, polycystic ovarian syndrome, gestational diabetes, as well as other chronic conditions. What advice would you give to healthcare professionals who have South Asian patients and are treating them? And also in terms of the lifestyle advice, are there any specific things that you focus on with South Asian patients?
Yeah, okay, that's great question. So one of the things that we know with South Asians is that we have a greater tendency to something called normal weight obesity. So what that means is, if you took say, a Caucasian person with the same BMI as a South Asian person, that South Asian is much more likely to have a higher amount of body fat. And we are much more likely to store that body fat not in safe places like subcutaneous fat, which is the fat on our hips and our thighs and buttocks, but actually around our abdomen. And that abdominal fat is more metabolically active. We're more likely to become insulin resistant, more likely to become leptin resistant as well. So that is a much more metabolically active location of fat that is more likely to drive insulin resistance. But not just that, that is one thing in part, but another lot of studies, things like the masala study, for example, that's shown us that we know that our chronic disease risk starts to hit us at a lower BMI in South Asians. So a normal BMI, we shift that curve slightly. We need to be slimmer because of the risk of normal weight obesity. But what we think is actually happening in South Asians is that, so for example, once South Asians become diabetic, they're much more likely to decompensate more rapidly. They're much more likely to have complications of diabetes. And we think what's really happening is not just in the womb, a lot of mothers have gestational diabetes. That triggers epigenetic changes in the fetus. And we should be maybe intervening at a lower BMI a lot earlier with South Asians, and really kind of increasing the amount of exercise and so on in women, in South Asians who are diabetic. They're much more likely to have gestational diabetes. And actually, we think that South Asians are chronically insulin resistant. And so what actually happens is by the time we're diagnosed with diabetes, we're beginning the decompensation. So actually what I say is we need to really be thinking about diabetes in South Asians a lot earlier, from preconception, from, in fact, really with everybody, we need to be looking at our BMI, our healthy lifestyle behaviors from really, really early on, but particularly with South Asians and in terms of BMI.
Definitely. So you're basically saying don't be lulled into a false sense of security when it comes to BMI. And,
absolutely.
The bigger picture. So there's a question there, which was, and just to say to everyone who's listening, we actually had the principal investigator of the masala study, Dr. Alka, on our webinar program last summer. So it is in the members area of our website in the recordings if you want to go and check that out. We've also had a previous webinar on type 2 diabetes with Brenda Davis, who is a world expert on this topic. So if you're interested in this topic, definitely check out the recordings. So one of the questions is, a lot of healthcare professionals say that gestational diabetes is down to pregnancy hormones and it isn't diet linked. What are your thoughts on that? Is there evidence to say that it isn't diet linked?
So even, so in my talk, I talked about heme iron, and actually prospective cohort trial showing that, for every 1 milligram increased daily intake of dietary heme iron carries with it a 50% increased relative risk of developing gestational diabetes. So we do actually know that our diet does impact on our risk of gestational diabetes. And it's not just that. I mean, it's maintaining a healthy gut microbiome, and of course having a good balanced whole food plant-based diet is the best thing you can do for that.
Definitely. And there are ways to enjoy all your cultural foods, but whole food plant-based style.
Absolutely.
As well. And someone has asked if you know any good recipe websites or websites for resources for South Asians who have type 2 diabetes.
So sorry, was it recipes in particular?
Yeah, recipes or other resources.
Well, actually, I think the vast majority of South Asian food is quite easy to adapt. So, for example, one thing that my family have always grown up, and I've grown up eating, is white rice. So try to switch to whole grain. I mean, we know that affects our risk of developing diabetes, having whole grains versus refined grains. So when we're talking about whole grains, a whole grain has all 3 layers. These are things from the grass family, things like rice and quinoa, even sweet corn is a whole grain. And this includes all three layers. So the outer bran layer, which is full of fiber and vitamins, the endosperm, the inner fluffier layer, and then the germ. So if we can switch to more whole grain foods, so switching out that white rice for whole grain rice, and maybe switching that chapati flour to a sort of stone ground whole grain flour, even multi-grain flours that are whole grain. These are all positive moves we can make. Try not to reheat oil. We increase the trans fats in those oils once we heat, cool, and reheat those oils. And so switch, for example, from sunflower oil to rapeseed or olive oil if you are going to use oils in your cooking. But if you can reduce the amount of oil, that's also really beneficial. And apart from that, I mean, we have a wonderful diet culturally, ideally, which includes a lots of nuts, seeds, legumes, lentils. It's just things like the whole grains and the use of oils, particularly vegetable oils that aren't so healthy, and the repetitive frying that we can try and tweak those things a little bit.
No, completely agree. And do go and check out our website, because we have tons of recipes there, including some Indian recipes that are whole food plant-based, as well as fact sheets for diabetes, as well as other chronic diseases. I would also recommend checking out Vegan Richer. She has a really good recipe website, and there's a whole oil-free section as well. So that could be really good, if, as I know, Diwali is coming up and other festivals as well. So it's a great way to dip your and try your hand at whole food plant-based Indian cooking, if that's something you're interested in. So one of the questions is there a role for chromium supplements in type 2 diabetes, or do you have any thoughts about that, about chromium?
I know that there were a lot of studies that, so the reason we think about things like chromium, for example, is due to soil depletion. So foods we eat may not have as much chromium and other micronutrients that they once would have had. And there has been this association between low chromium in diabetics and non-diabetics. I think that I'm in terms of supplements, this could well be a factor. I'm not absolutely sure, but I know that the kind of research, essentially with my patients, I tend to focus on more lifestyle, and things like supplementation tends to be really, really rationalized and kind of only if necessary, because a lot of the research coming out there is actually, if we don't deal with our foundation and eat whole foods, and adding supplements isn't just a well, I'm covering my bases. We can actually cause a lot of harm by adding supplements. For example, antioxidant supplements. I'm sorry, I will come back to chromium, but antioxidants, for example, we know that in smokers, if you push a whole load of vitamin E or vitamin C, you increase their risk of lung cancer. And that's because antioxidants work in a network. And if you drench it with just one of those components, you make those networks not work so well. And actually, I think there was the Iowa women study, and it shows that if you start to increase all-cause mortality with things like supplementing iron. So really all supplementation has to be very, very, very rational, in my opinion. So if you can get all of the things you need from your foods, that should absolutely be your primary. If you can identify things like B12, of course, that in a whole food vegan diet can be tricky.
How about vitamin D, which obviously can, I know it can impact insulin sensitivity? Do you recommend South Asians in particular take, special precaution? But I know at this time of year, the government recommendation is that everybody in the UK, we supplement with at least 10 micrograms of vitamin D.
Absolutely, yeah, and I do, because I mean, I know that there are some vitamins that, specifically vitamin D, vitamin B12, that we know they're absolutely fine if we add them to our system. And vitamin D in particular, as you said, in South Asians, so our skin protects us from skin cancer, but it also puts us at risk of low vitamin D. And so I would advise get your vitamin D level checked, especially as we're going into this time of year. A lot of people, even white people that I have as my patients, they have low vitamin D levels, probably because we're sitting indoors and we're working at our computers, and we're not, even if you're not South Asian, you're not necessarily getting the level of sun exposure you need to maintain that vitamin D level. So I meet a heck of a lot of people, even during summer, who have low vitamin D levels. So yes, I do recommend you top that up, and that's a really high dose of vitamin D regimen for about 5 days, usually about 100,000 units. It depends what your starting level is. So if you have a low vitamin D level, top that up first, and then aim for 800 to 1,000 units a day as a maintenance dose once you've topped up. So yes, I do. In terms of the chromium, I'm not absolutely sure. I'll be honest. I am always a little bit on the back foot about supplements, unless they're very, very, very rational.
And do you have any thoughts about tests that are sort of talked about quite a lot in the USA, such as fasting insulin? I know that here we look at HbA1c and fasting glucose. What are your thoughts on the best measures to check for type 2 diabetes or pre-diabetes?
I mean, so we do really just use, now we really just use HbA1c mainly. And what I would say about that is, I think that in my opinion, that's wholly adequate. I don't think we need to be worried too much about whether we are now pre-diabetic or diabetic. Just that tendency is enough for us to need to act and start to shift ourselves away from that. I mean, we know of all things diabetes is reversible. It's one of those very reversible things. And now even the complications of diabetes are reversible, we can see. So, I mean, I don't think it matters so much what the measure is. I think that you can never really, especially as a South Asian, start too early. And all of us, we're kind of recognizing that actually the way we think about most chronic disease is focusing too much on numbers and driving down those numbers and changing those numbers. But that isn't really treating the person, and it's not really treating the disease. And that's what we see with these medications. They're actually not getting the same kind of results as lifestyle interventions. So even where you drive down the numbers, you're not driving down the risks of those diseases, and we may even be causing harm.
That's wonderful. I'm just going to launch a quick poll to get everyone's feedback. And I want to ask you a final question, which is, I would love to hear a bit more about what you're doing now with My Wellness Doctor, and also how people can get in touch with you and stay up to date with your work, follow you, and support you as well. That's
really, really lovely. So My Wellness Doctor is a company that I co-founded, and we really help anybody with any kind of chronic illness. And we really work individually with people to try and help them with their sleep, help them with their exercise, help them really with their diet. This has given the biggest impact compared to everything else that I ever do. And also in terms of their stress. And I think that, you know, after COVID, with our modern lifestyles, with our Western dietary patterns, lifestyle medicine is really how we should be looking to treat all of our patients. And I can't wait till this is available on the NHS. I know there are a lot of GPs who would like to incorporate lifestyle medicine, but that 10 minutes with each patient just simply isn't enough. And so that's why things like people like me have started our own practice, because it is deeply rewarding to be part of that journey with people and to really shift their health trajectory. So my website is mywellnessdoctor.co.uk. I'm on the register with plant-based health professionals. You can find all my details there. I have an Instagram account and a Facebook account, but yes, you can reach me at mywellnessdoctor.co.uk.
Wonderful. And do you have any other tips that you want to share with everyone, just for in terms of type 2 diabetes? Is there anything that you just want to leave people with, a message when it comes to that?
I mean, I really hope that people have really come away from this talk feeling optimistic, because actually, you know, when we're talking about all these things, I know that very low calorie diets and these dietary replacements and these sort of ketogenic diets, and these are kind of the way that the NHS has been looking at type 2 diabetes reversal. But actually, we're not seeing the outcomes in terms of For one thing, they're very, very difficult to stick to. And two, they don't result in those long-term outcomes. But on the flip side, having delicious food that is full of antioxidants, that's whole food, plant-based, I know it sounds, for anybody who hasn't begun, it sounds like, gosh, this is a really big thing, but there's a lot of support out there, like plant-based health professionals. There's a lot of resources out there. And actually, just allocate one day a week, for example, one meal a week where you focus on something like this and try and be consistent. Because for all behavior change, we know going from doing nothing to doing something is where we see the biggest health benefit. And that behavior change is all about just being consistent, even if it's something very, very small. And I would begin with a whole food plant-based diet is where I always see the best results for all of my patients. But all the other things are important too.
No, absolutely, all the pillars, but I love that message that we often find that when people adopt a whole food plant-based way of eating, a lot of other things fall into place, and there's a beautiful synergy between all those different pillars. But
Absolutely.
We have so much information on our website. I will definitely be checking out My Wellness Doctor, and I will be sharing the slides and the certificate with everyone. If you enjoyed this talk, please do encourage your friends to join Plant-Based Health Professionals and view this talk and all the other webinars that we have, as well as our other resources. And thank you so much for joining us and for such lovely comments. I really couldn't keep up with them. I was reading them while we were chatting, and I will send you a snapshot because they are just really lovely and everyone has thoroughly enjoyed this evening. So
I've enjoyed myself. Thank you so much for having me here, and thank you everybody for joining.
Thank you, Sundhya, and I'll see everyone else in a couple of weeks' time. We're going to be discussing plant-based diets for sports nutrition, which is a really exciting topic. Good night, everyone.